Hello, everyone. I'm Ron Rolfing, and I'm the Preferred Vendor Coordinator here at ACAP, and I'd like to welcome you to our latest Education Series webinar presented by Softheon. With me today is Eugene Sayan, CEO and President of Softheon. He will be presenting the webinar, Your Guide to Navigating CMS New 1115 Waiver Approval Process. A little bit about Eugene. He leads Softheon in its mission to develop innovative solutions for healthcare payers, providers, and government agencies. Since 2000, he has been responsible for the corporate strategic vision and direction. Prior to Softheon, Eugene led big data and process management initiatives for Fortune 1000 companies and completed a tenure at IBM. He received a bachelor's degree in electrical engineering and telecommunications from Istanbul Technical University and a master's in computer science from New York Institute of Technology. As most of you know by now, the purpose of the ACAP Vendor Education Series is to share the preferred vendors' vast knowledge on topics that are of interest to ACAP health plan members. But before I turn it over, I have a few housekeeping items. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines, and these guidelines can be viewed on our website. We will be recording today's call, and we'll post the slide deck and recording on our website, and you'll receive an email when these items are ready to view. We do have a few more webinars this week, so if you can, take some time out to view those. And our list of preferred vendors is on our website. Look to the top of the page, click on Preferred Vendors, and this is a great place to look when your plan is issuing an RFP. During the call, you can ask a question at any time. You can do this by typing in your questions in the question box in the control panel and hit send. And all questions will be answered at the end of the call. Now I'd like to pass it over to Eugene.
Thank you, Ron, and good morning and good afternoon, depending upon where you are today with us. Thank you again for taking the time to join us this morning or this afternoon. We are proud and privileged ACAP a preferred vendor. Been doing quite a few series. In fact, we used to do quite a few in the early days of ACA, given our focus around ACA and in general, public and private exchanges. And this morning topics will be somewhat relevant to those early days of the ACA conversation. Here we are 4+ years later from the time that the ACA went into effect. And we are now in an era that one may call ACA 2.0, transition from Obamacare to Trump care. There's not a day goes by that we hear something on that topic on the media today. And this is, our opening slide. The healthcare is a national issue. As we all know, our healthcare spending is expected to exceed $3.2 trillion, 18 or 20% of GDP. Despite all the efforts, the cost of the medical expenses, if you will, continues to rise up. There are some new payment models are being implemented aimed at controlling the rising costs, and the new delivery systems are disrupting the existing relationships. Another important topic is the consolidation. Very recently, we heard that the Aetna and CVS merger. It is one may view that as a quite disruptive. It may change the way the healthcare is being provided and serviced from the very much a CVS clinics with a kind of a 360-degree view of a healthcare coming from every angle. We also see that the last couple of years we've seen a lot of innovations and new entrants. The likes of Oscar Health and a few others have the potential to disrupt the traditional market environments, providing consumer-centric tools in order to reduce the healthcare costs, as we all seen it have been happening. And then traditional players are also looking for ways to remediate those challenges, if you will, through innovative programs. In some cases, they are spinning off their own startups, if you will, and taking a critical part of their business function and then handing it over. And the healthcare reform has become really the kind of everything came together. Its primary focus was about improving quality, access, and lowering the cost, though it has been very challenging. The sectors in the industry are seeing an increased compliance requirements as a result of ACA where we are today. Obviously, ACA kind of in a way leveled the field, if you will, based on a standard products or essential health benefits. And also the no preconditions were allowed to in the process, and then the program was being positioned as a one notch above Medicaid, and for that reason alone, we have the opportunity to work with quite a few ACAP health plans, being trusted by them to build their and operate their ACA exchange environments altogether too. If you look into the next slide, is about healthcare is political. It is a national topic. It's also political. We'll go back and refer to this particular slide throughout the day, but I think that's what's noteworthy in this slide itself is the, as we call, the Seema Verma influence. Seema Verma is the architect of HIP 2.0. HIP 2.0, Healthy Indiana Plan, is a second version of the initial program started in 2008 as Indiana will call it, as the nation's first consumer-driven health plan for Medicaid beneficiaries. Back in 2014, under ACA, HIP 2.0 was funded as a 1115 waiver, which then truly transformed the Medicaid operations, particularly in Indiana. And we'll talk more about the metrics around that program altogether, all the way from the use of HSA like savings accounts called power cards to the other forms of compliance requirements, acceptance rates, and so on and so forth, or grace periods in ACA like program Indiana has implemented as a HIP 2.0, as we call it. So the next solutions, let's discuss what's really being circulated around. The Medicaid expansions, as we have discussed very earlier, commonly referred as the 1115 waivers, was basically filed by different states under the form of a modernizing or giving the states the opportunity to create their own interpretation of particularly Medicaid implementations. So under the 1115 Medicaid demonstration waivers, the states has an avenue to test new approaches in Medicaid that differ from the federal program rules. The waivers can provide states considerable flexibility, and they can operate their programs beyond what is available under current law, which can have significant impact on the program financing. As I mentioned earlier, Indiana HIP was one of those programs. And there are 33 states so far, as of September 2017, applied 41 approved waivers. The waivers became very popular also under ACA as an ACA expansion waivers. There are a few states look for those waivers as part of the ACA's Medicaid expansion, in part because they could not otherwise secure the political support to expand the coverage. As of September 2017, the 7 states, namely Arizona, Arkansas, Iowa, Indiana, Michigan, Montana, and New Hampshire, have approved waivers to implement the ACA Medicaid expansion in ways that extend beyond the flexibility provided by the law. As of March 14, 2017, the CMS sent a new letter to the governors that signaled the willingness to use 1115 authority to support innovative approaches to increase the employment and community engagement to align with the private and public initiatives that is targeted for the Medicaid population. Several states with the ACA expansion waivers already have approval to implement the provisions, as in the case in New Hampshire and as well as in Nebraska in a very similar iteration altogether. Iowa is looking for, as you may or may not know, that the 1115 and combined with 1332 waivers to create their own exchanges. This year, they forgo that effort for the time being, So we're all anxiously waiting for the final version of that tax reform, how it may influence the ACA in general and Medicaid as it relates to it. And I think we're going to start seeing a lot more creativity around 1115 waivers. The number of states have waivers pending at CMS that include the provisions not previously approved under work requirements, drug screening and testing, eligibility time limits, and the premiums with disenrollment for non-payment to traditional Medicaid population. And some of the requests are part of the expansion waivers. Others may apply to the traditional population as well. Stakeholders are waiting to see how CMS will respond to the pending waiver requests, especially those that have not been approved in the past could lead to a decreased program enrollment. If we go back for a moment to HIP 2.0 program, as I mentioned that in early days, dating back to 2008, Indiana was experimenting with this program earlier. And back in 2014, under CMS as a 1115 waiver, the program got implemented. So it had multiple components to it. It is as we said it earlier, it's a private Medicaid program we often refer to. And it is becoming the model for quite a few other states. And there are some few states are in the process of seeking for their waivers, states like Kentucky. CMS has worked at varying capacities, if you will, with states like Michigan as well in the process. And the primary purpose is about really enabling the legislation and negotiating the financing level with the states and hospital associations and developing a waiver program that basically addresses in a couple of areas. One is reducing the number of uninsured. It has a similar type of a mission in mind like ACA. We're not making any political statements, bear in mind in here, but it's nevertheless, this is the intent of the program as it was presented. It's also designed to improve the low-income residents' access to the healthcare services, very similar to ACA, again, Medicaid expansion programs. Promoting the value-based decision-making, primary care and preventions, chronic disease progressions, evidence-based healthcare services, and then most importantly, perhaps, they ensure the state fiscal responsibility in program management. As of 2017, a little over 400,000 numbers. I believe, in fact, numbers might be even close to 500, maybe slightly above. As of last year, there were 4 carriers were participating in the Indiana program as the MCOs. And there are various success factors being reported by the state over the last couple of years. So one of the cornerstone of the HIP 2.0 program is the premium billing member responsibility. So individuals might be subject to a premium billing as little as $1. And subsequently, their contribution and then the state contribution goes towards a POWER account. POWER stands for Personal Wellness and Responsibility Account. This is an HSA-like account. It's not an HSA. It does not have the triple tax advantages as we all know in HSA space. It's not truly a rollover. You can only roll over 50% of the outstanding savings or whatever that's left in the account year over year. So the individual that set up to its first $22,500 in his or her name will be set up as a POWER account. And then the medical expenses for cover services are paid with the POWER accounts. And state will contribute most of the amount, as we just said it earlier. When you pay your monthly POWER account contribution, it is deposited into your account, consumer's account, and the consumer will receive a monthly statement that shows how much money he or she has remaining on the account. Cover services, again, are paid by the MCOs and the states paid by the states, servicing by servicing MCOs. And if you manage if the consumers manage their health accounts and use their POWER account wisely, they may have some left money in the account, as we said earlier, and some of those money will be then roll over to just next year's contribution. So there's an element of savings associated with it. Again, as I said, it's not a true HSA account. it does not have some of the long-term tax benefits on the investment side. But we have heard the HSA notion over the last year or so, both on initially from HCA to the BCRA, especially under the Cruz Amendment, about the use of HSA accounts for the purpose of, in fact, for premiums, that the consumer's responsibility, and then raising the HSA limits to equal to the out-of-pocket expense, if you will, so that basically the limit can be raised from $3,700 individual, $7,500 family, to as high as $15,000, $20,000, depending upon. So again, these were the statements were thrown around in the early days of the debate a month or two ago, and we don't know what the final version may come up, let it be in the tax reform bill or the subsequent bills that the current administration is looking to introduce with the coming years. Proceeding with the 1115 waivers. So let's go back, look